We're very excited to have Amy Legg speaking. Amy is a pharmacist at the Royal Darwin Hospital, the top end health service, and she's also doing a PhD looking at the combined nephrotoxicity of vancomycin and beta-lactams. And really, we heard from Amy last year, but we're hearing again from her this year, taking a step back and really telling us about, I was going to say a day, but it's going to be a whole week in the life of a HIF and OPAT pharmacist. So,
thanks so much for the opportunity to present. My name's Amy Legg. I'm a clinical pharmacist up in the Northern Territory in Darwin. I'm an antimicrobial stewardship pharmacist. I've had a lot to do with a very interesting patient that we've had up here. And so I'm going to be talking about 5.5 months in the life of really an honorary NTM OPAT pharmacist. I'd like to acknowledge the traditional owners of the land in which I am, the Larrakia people, and pay my respects to their elders, past, present and emerging. Just a slide here to make sure you're all aware of where the Northern Territory is. And then within the Northern Territory, as I mentioned, I'm based up in Darwin. And this patient certainly started their journey in Darwin getting medications stabilised, but their goal was to get back home to Borroloola. Borroloola is about as isolated as any township in the Northern Territory can be. It's 970 kilometres from Darwin and about 380 kilometres from the highway. So from the highway, if you're taking a detour, it's a 760 kilometre round trip with not much in between. You can see here on the map it takes about a 10-hour drive depending on the quality of the roads and how much rain there's been. Specifically thinking about the OPAT in his setting, one of the things we do always consider, particularly related to drug stability and solution, is what's the temperature. A lot of the drugs that we have information about stability for really only has temperature data up to about 25 degrees. And we can see here the average temperature in Borroloola, the maximum is never really below 30, let alone below 25, although it does dip to below 25 in the lows. But certainly it would be an area where trying to minimise extreme temperatures would be difficult. Some work that we've done at the Royal Brisbane, where volunteers carried elastomerics with a temperature probe, showed that even getting into a hot car for a short period of time can create huge spikes in the temperature of the bag to above 50 degrees. And I think that would certainly be an issue in an area like this. Luckily, she didn't need an elastomeric device or 24-hour infuser, but it would definitely have been a difficult situation to facilitate. So this is our patient. As you can see here, for the preceding year, she'd had a variety of regimens for her pulmonary Mycobacterium abscessus. And when I came into the picture in 2020, the plan was for her to go on tigecycline via a PIC, inhaled liposomal amikacin. She hadn't tolerated inhaled parenteral amikacin due to bronchospasm, but we were hoping that the liposomal form might be tolerated. And we were going to start her with oral linezolid and oral clofazimine, which she had had in the past. Her current medication list was as shown, and the first question that came to me was really about, can we safely initiate linezolid in this patient? So she had two drug interactions that require consideration related to the serotonergic effects with linezolid. So she was on an SSRI, escitalopram, and she was also on mirtazapine. And we know linezolid is an inhibitor of MAO, monoamine oxidase, and has had many reports of causing serotonin toxicity, although the information about this is very controversial and seems to change every time you look at a new article. What we decided to do, we really wanted to try and ensure that her mental health wasn't affected. She had been stabilised for a long time on these medications. But in conjunction with the psych team, we weaned her off her SSRI and left her on her mirtazapine. That's worked really well, and the mirtazapine's been increased while she was on the linezolid, and we didn't see any issues with serotonin toxicity. The other issues with linezolid around toxicities include myelosuppression and optic and peripheral neuropathy. The peripheral neuropathy has become significant really to me in that it's quite painful for patients, and it's largely irreversible, or it can be irreversible. So it's really important that we are monitoring for this. The other question that routinely comes up is around therapeutic drug monitoring of linezolid and whether there's a role for B6. We wanted to also get this lady in Borroloola on liposomal amikacin, which involves completing forms and then meeting with the company in the US between Borroloola Clinic, Catherine Clinic, and Darwin, which was a logistical nightmare. Then we did more forms to get stock. Then we ordered, and we had to do more forms because we needed more supply. They only like to give 4 weeks at a time, but we were really worried about potentially roads getting cut off, so we ordered more. Unfortunately, she had 2 ADRs. Firstly, she had a rash, which probably wasn't related to the ALS, but then she did have a sensation of feeling like she was drowning and she couldn't continue on. So we did some more forms after the ADRs, and then it was ceased. But I was really proud that we were able to get liposomal amikacin to her in Borroloola. The other thing while working with this and the company was just how much information they have, and particularly some really helpful advice on managing adverse effects. So that's the device, and that's just some information about taking it I won't go through, but you are quite busy when you're on liposomal amikacin. Just quickly to talk about her tigecycline. So she had a PIC put in, and the clinic in Borroloola have managed the PIC and the tigecycline beautifully. One of the questions that we had is really for her, daily tigecycline dosing was going to be the optimal so the clinic could manage it. And we wanted to try and work out, is daily dosing of tigecycline going to be detrimental to her in terms of efficacy? So there have been some targets proposed by the literature of what the AUC to MIC ratio should be for Mycobacterium abscessus, but the Monte Carlo simulation showed that doses of 200 milligrams a day were really needed to achieve those, and the probability of achieving the AUC for nausea is reaching 1 with those doses. Additionally, there was a recently published article on therapeutic drug monitoring and NTM that suggests that tigecycline should be dosed twice daily. But there is clinical evidence that patients who received 50 milligrams daily for rapid growing Mycobacterium had clinical success. And so again, to try and facilitate being able to administer these medications in a remote location, we went with 50 milligrams daily. She has struggled with nausea, as we've heard, is a very difficult complication of tigecycline. The data really supports potentially giving it postprandially or after a snack and the use of antiemetics. But I really want to highlight what the patients were talking about, which is to focus on what works for them. We don't have great data on what works for everyone, but every patient is different, and I think we should try everything in our wheelhouse and just see what works for them. So after she couldn't take the liposomal amikacin, we also had to cease the linezolid due to severe peripheral neuropathy, and the new plan for medications was bedaquiline, continuing on the clofazimine and continuing on the tigecycline. I again was very excited to think that we could have one of probably only a handful of patients in Australia on bedaquiline being in Borroloola. She was on multiple QT prolonging agents, and we do really worry about potential cardiotoxicity with bedaquiline. We know it can be a QT prolonger, and there was a study that showed some early death where the cause was unknown, and there was concern that it could have been QT related. The WHO has guidelines about checking QTs, and again, the clinic at Borroloola were more than happy to do this, and we coordinated with them about what bloods we should do first and then what the plan for QT monitoring would be. Just recently, some data was published from the deliberate study that showed that the mean increase in QT with bedaquiline was only 12.3 milliseconds. Additionally, we wanted to try and find a safe option to give her some pain relief for her peripheral neuropathy, and one of the options was duloxetine, which initially we were concerned about, but when I looked into it, it's actually a drug that's not known to affect the QT, so it could be a really nice choice here. I did get some thoughts from one of the nurses in Borroloola about how they've been managing this patient, and I just wanted to share those with you because it's really interesting and insightful. So he noted that there has been some challenges, but in the management of this patient, they've utilised a case management model where one nurse has oversight of the current plan with the GPs locally, so that there's continuity around treatment and patient care, in particular for medication management, and provides a reference point for the patient if she has any questions. Additionally, he noted despite being in a remote area, they've had great service and support from the multidisciplinary team involved in the care, so it's made it easier to get expert advice in terms of side effects, medication changes and precautions, and even questions that have arisen during her care. They've also done mini case reviews with all the local staff, so that particularly locum or agency nurses have all the information they need around her medications, including indications, administration, side effects, special precautions, and such things as the fact that these are QT prolongers. He also highlighted that logistically there are also challenges around medication supply. So they've been ordering at least 2 weeks in advance, just in case the roads get stuck in wet season. But I really think this can't just happen if a patient just gets sent out. This has involved a lot of people. It's involved a really nice governance framework, and it has been a wonderful success for the patient in terms of her being back at home, which is what she wanted. And she has had clinical improvement as well in terms of symptom resolution. And I really want to highlight the role that the nurses in Borroloola have taken, and definitely the GP in being the on-the-ground experts in her management. So to summarise, patients all over Australia need specialist medications, and we can facilitate that, but we have to take the big evidence and distill it down to our single patient. If you have a good team, you can facilitate this. And pharmacists are vital, but make sure your recommendations are doable. Thanks so much.